Hello, everybody. This is Dr. Al Hewer. I am Terry Shenfield's partner in A&T Respiratory Lectures, so we're co-owners. I still teach as a professor at Rutgers University. I edit textbooks, including co-editing Egan's Fundamentals of Respiratory Care. So if there's any nurses that have joined us, that's pretty much the cornerstone textbook in respiratory care, as well as two others. So I just came out with the clinical assessment textbook. Literally, it's just coming out now. And I'm the sole editor for that textbook because my esteemed partner in it, Dr. Craig Scanlon, passed away. But in any event, in both of those textbooks, we go into a lot of these concepts, including an overview of exercise stress testing in those. So this particular presentation is going to focus on the following learning objectives. The first of them is to review some key definitions to provide, if you will, a foundation for the subsequent slides that we'll go into. We'll describe the indications and contraindications for cardiopulmonary exercise stress testing. We'll examine some of the basic equipment. And if you'll allow me to, this image that's actually on the greeting slide here, that shows you probably a pulmonary function technologist, a registered respiratory therapist. It shows you a quote unquote patient who's on an ergometer, okay, is actually on a exercise bicycle, also has equipment to actually measure things like inspired oxygen levels, basically the amount of CO2 that's produced, and done again with a mask that's actually strapped to the face there. And then the computer does a couple things. Number one, it allows the, if you will, exercise level, the actual amount of exercise stress that's placed on the patient. That is, if you will, addressed by what's called work. Okay, it's not arbitrary. So the load, the exercise load that's placed on the patient is not at all arbitrary. Okay, it's actually based on different protocols, a few of which we'll actually talk about in the presentation. So the computer allows the protocol, the exercise load protocol, to be followed, and it also records key data. So it records key data. So back to the objectives. So again, examining some of the equipment. I have additional slides in this presentation that talk a little bit more about the equipment, review the actual setup of the equipment, but it's more than just that. It's actually preparing the patient. It's just all of the preparation that's involved, the monitoring that needs to go on during the procedure. Because you can imagine that, for example, if the patient is getting an increasingly heavy load of, if you will, stress, exercise stress that's actually placed on them, they need to be monitored very closely, for how they're tolerating it and for the outcomes measures, but also to ensure that they're not getting overstressed and starting to do things like, their sensorium is affected, their oxygen, their if you will, their saturation is dropping, their heart rate is going, too high, and or they're actually experiencing a dysrhythmia. So they're monitored beforehand, and then it's afterwards they're monitored, but also there's a lot of computerized tabulation that goes on and interpretation as well. So that's really the next bullet point, is evaluating and interpreting the test results. We'll take some classic examples and talk about those. But I also included a few slides on the 6-minute walk test. The 6-minute walk test has not replaced cardiopulmonary exercise stress testing altogether by any stretch of the imagination. But in certain cases, it may provide enough data, depending upon what the objectives are, to basically result in the exercise stress test not necessarily being needed, okay? And then perhaps most importantly, I'll provide you guys with additional key references if you want to drill down and learn more about these topics. So definition, goal of cardiopulmonary exercise stress testing, okay, is a definition. Again, there's various definitions out there, but they're pretty much all very similar to this. So cardiopulmonary exercise stress testing evaluates characteristics and characterizes, quantifies the physiologic response of the heart, lungs, and muscle to an increase in physical stress. Now, the stress we're talking about is not the kind of stress that necessarily that you experience when you're trying to, get to a place fast and you're in traffic. And that's a related but a different type of stress. The stress we're talking about is what I alluded to a little bit earlier, and that is the exercise stress, if you will, the tension that's on a ergometer or an exercise bicycle, the speed and or elevation that is on a treadmill. So when we talk about, physical stress or exercise stress, that's what we're talking about, the load, if you will, the stress load. The goal of a cardiopulmonary exercise stress testing is to evaluate the physiologic response of the heart. And again, the reason why I have the question marks there is the heart, that's not the main focus, but the heart, the lungs, and the muscles to an increase in physical stress. So really we're looking at, is the etiology the heart, question mark? Is it the lungs, question mark? Perhaps. Is it more of a metabolic thing, the muscles? Okay, that there's some issue with the muscles and they're the limitation. So it can be heart, lungs, muscle, and or a combination of them. So one of the things that the 6-minute stress exercise or the 6-minute walk test will not do, it will not in any way distinguish between heart, lungs, muscle, some sort of a physical limitation. Won't do any of that, okay? The cardiopulmonary exercise stress test will in large part do that, providing it's performed properly. So some major indications, the evaluation of dyspnea, okay? So the reality is cough and dyspnea are two of the most common, if you will, signs and symptoms of pulmonary disease, okay? But they're not specific to pulmonary disease. So they're commonly found in pulmonary disease. Guess what? They can also be found in deconditioned individuals. They can be found in individuals that have congestive heart failure, all right? They can be found in patients that have asthma, so there's a lot of different, reasons why it can be individuals who claim they're short of breath, but in reality, they're not, okay? Or there's nothing really wrong with them. They may be having a anxiety attack and they're dyspneic because of that, because of some sort of a psychosocial response to some sort of a stimulus. So really the evaluation of dyspnea, and again, trying to evaluate, distinguish between cardiac or pulmonary, okay, or among cardiac, pulmonary, and a peripheral or a muscular limitation, right? It's also, believe it or not, helpful in determining folks that are what's called malingerers, okay? And I'm not going to spend a lot of time on malingerers because I'm not saying that there's a lot of folks out there that are faking it, right? But that's basically what a malingerer is. Malingerer is saying, I can't breathe right, I can't breathe, I'm short of breath, and there's really nothing wrong with that, okay? So again, there's a small percentage of people, but perhaps somebody who's, claiming that some sort of an occupational exposure may have actually caused that. By the way, we know that in certain cases it's real, that there was some sort of a welders, for instance, coal miners in the day, all right? So we know that there's some occupations that are out there, individuals that work with asbestos, which is a heavily regulated, substance now. But frankly, when I was in 8th grade and we were doing 8th grade lab, we had what's called asbestos pads. That you had the torch that was on the asbestos pad, and it was no big deal. Now it's obviously a huge deal. But really, we know that there are some occupational exposure that are very, very real. Okay. But we also know that unfortunately, there's a minority of people out there that are they're really not sick. They just don't want to work. Also, another indication is detection of exercise-induced bronchoconstriction. All right. So we know that there's a subpopulation of asthmatics that when they're exercising are exposed to, basically asthma-like symptoms. Okay. Worse yet is there's a subset of them that when they're exercising in cold air, okay, that it can be even a kind of a confounding effect. By the way, that population are one of the few subpopulations that when an individual becomes bronchospastic and they use their rescue inhaler, okay, more than, let's say, twice a week, That's a subgroup that's not necessarily categorized as uncontrolled asthma. If we know it's the cold air, particularly cold air and exercise that's causing it, and they need to use their rescue inhaler, they're not necessarily categorized as unstable or uncontrolled, okay? But do understand that unlike the old days, if an individual, if they're in neither of those categories, not cold air, not exercise induced, and they get, very, very short of breath and need to use their rescue inhaler more than a couple of times a week, they're considered not well controlled. Okay, and it really is, there's gradations to that. It depends how often they actually have to use it and that sort of thing. Detection of exertional desaturation. So and again, these are not mutually exclusive. You can have individuals who have a pulmonary limitation. They have exertional desaturation. So they get out of breath, but they also desaturate. You can get some that get out of breath and they don't desaturate. You can get a small population of some that slightly desaturate and they're not much more out of breath. That's a much smaller population. Usually if you get a desaturation, these individuals will actually get dyspnea at the same time. Disability determination, what I've alluded to earlier, and maybe there's a real exposure. They want to see how disabled the individual is. What is their limitation to exercise? At what point during the protocol, during, if you will, the stress load, the increase in stress load, do they either have indications where they can't continue, or again, there's some other, they go into what's called an anaerobic threshold, which I'll talk about. Pulmonary rehabilitation to screen patients pre-pulmonary rehabilitation. Now, I will tell you that it's less common to do cardiopulmonary exercise stress testing prior to every time an individual goes for pulmonary rehabilitation, okay? But it is pretty much standard to do some form of pre-screening, and it may be the 6-minute walk test, okay, to determine before pulmonary rehab, they were able to do this. Afterwards, they've increased their functionality in some demonstrable, measurable fashion. And again, at the end of this presentation, I'll talk briefly about the 6-minute walk test. Pre-op evaluation and risk stratification. So in some cases, it is to determine, if an individual has bona fide pulmonary disease, okay, and let's just say you have an individual who has moderate COPD and another individual that has severe COPD. All right, so the differentiation there would be if a cardiac, if you will, surgical team is operating on both of those individuals, you'd figure the individual who has severe COPD would be at higher risk for poor outcomes than the individual that has, if you will, moderate or mild COPD. So it's really to determine if a surgeon's operating on a riskier population overall, then their outcomes should be risk adjusted. So to provide some measure of risk adjustment. The other thing regarding surgery, it may identify individuals who maybe are not good candidates. They're too sick that their limitation to any sort of an exercise, load or stress is too limited, and the likelihood is they really would not. They're just too sick. They would not do well. And also to assess response to therapy. And I alluded to rehabilitation, maybe that, but there are other obviously forms of therapy, many other forms of therapy to try to, if you will, get an idea, did we get any benefit from this that's actually measurable and demonstrable? And let's look at some contraindications. I'm not going to read each and every one of these, but some of these you would actually suspect. The first three, for example, acute MI, and we're really talking about something recent within the past 2 to 3 weeks. Unstable angina or angina, unstable dysrhythmia or arrhythmia, where we're not talking about somebody who has one PVC every 5 minutes or 10 minutes, somebody who's throwing PVCs, a couple of times a minute, sort of thing. And then you actually have disease states. So the acute endocarditis, myocarditis, pericarditis, really, the related disabilities or conditions where there's an inflammatory process in the heart muscle or around, the sac that holds the heart. Many times, though not all, it may be related to an infection. There are other times that it's actually related to an injury, or in some rare cases to some certain medications that are administered. Syncope, so we're really not talking about somebody that fainted once 5 years ago, but somebody who's having repeated fainting episodes or episodes of syncope. Severe asymptomatic atrial stenosis. So again, there's degrees of atrial stenosis, but you get the idea. Uncontrolled CHF and the others that are mentioned here. Uncontrolled asthma, individuals who are starting and their SATs are already, really kind of in the mid to lower 80s or less than that on room air, probably not a good candidate to participate in a cardiopulmonary exercise stress test. And then some relative contraindications. So here we have, well, it's not an absolute deal killer, but you got to determine, the degree of severity. So, coronary artery. So 3V is 3 vessel coronary artery disease, severe arterial hypertension. So we have the systolic that's around or north of 200. Pulmonary hypertension is really overall. Tachyarrhythmia. So some of these are depending upon, the severity, what brings it on, high degree AV block. So really when you have somebody that has, maybe if it's just a first degree heart block, not necessarily a deal killer. I will tell you if it's, a third degree heart block, it probably is. Patient probably should not until they figure out what's going on with that and treat it, hopefully successfully. Cardiomyopathy. So, the individual, usually it's the, if it's a left ventricle that's enlarged, but sometimes it absolutely can be the right ventricle as well, where individual develops, some element of, of an enlarged heart and, a sick heart muscle. So cardiomyopathy. Electrolyte abnormalities, particularly potassium, but not only potassium, because all the electrolytes, the exchange of positive and negatively charged electrolytes is really what accounts for the regular heart rhythm. It sounds kind of weird, but the conducting is really conducting of negative and positive, exchanging, but conducting of negative and positively charged ions, which really accounts for both our cardiac and our skeletal muscle contraction. Moderate stenotic valvular disease, complicated pregnancies, orthopedic impairment sometimes can do that. Although, you'd think maybe somebody who has lower extremity arthritis, some of these tests can be modified in order to facilitate like an arm ergometer. So I don't mean to imply when I show you the equipment a little bit later on that the patient needs to absolutely, be able to go on an ergometer, an exercise bike, or they need to go on a treadmill. Typically, that's what we're looking for, but there's adjustments that can be made both to the equipment as well as to the protocols for increasing the stress or the load that's on the patient. Screening and initial evaluation, so history, so tobacco use. What I will tell you is in the day, 20 and 30 years ago, pretty much if someone was an active smoker, they really didn't want them, doing exercise stress tests. They didn't want them participating in pulmonary rehab. Now the mindset is a little bit different, and that is, that it pretty much provided there's no absolute contraindications, and provided the patient is actively enrolled in a tobacco smoking cessation, nicotine cessation program, and there's none of the other deal killers, they would be allowed to participate. But you'd want to know about it. Okay. Any medications that they're on, but particularly certain classes of medications, including pulmonary medications, cardiac medications, and anything that may actually, affect even beta blockers. The old school beta blockers can, in certain patients, result in some bronchoconstriction. So you want to know if the patient's actually on that, or they can render medications such as albuterol that are obviously bronchodilators less effective when a patient started on a beta blocker. Tolerance to normal physical activities. So, in general, do you get, out of breath when you're doing X, Y, and Z, climbing stairs, for instance, going, chasing after the bus, whatever. Any distress symptoms, just getting overall, and any contraindicated illnesses, including the ones that, I referred to a little bit earlier. Physical exam, you can just see what we have listed here, but doing the height, the weight, et cetera. Often they're calculating with the height and weight, they're calculating BMI, body mass index. And when someone's BMI is starting to approach 40 or is north of 40, no bueno. It's really, I don't want to say it's not an absolute contraindication, but it's a relative one. And the higher up it is, it may actually end up being an absolute contraindication. ECG or EKG, whichever you choose. But again, very useful in screening to determine whether or not there's the presence of any of those deal killer dysrhythmias. Pulmonary function tests, and again, we'll talk more about diffusing capacity. It's one of the ones that's listed here in some of our other presentations, but lung volumes, diffusing capacity, arterial blood gases, and the like. Prior to the test, so things that an individual would do almost as if they're going to perform any rigorous exercise. Loose fitting clothes, comfortable shoes, abstain from coffee, cigarettes. Again, so they're making some allowance there. They're not encouraging people to be active smokers, but they're also recognizing that may have actually put them here. And if this helps screen them, and they may, they're trying to quit, but they're not quite there yet. We maybe shouldn't delay the exercise stress test because they're still actively smoking, particularly if they're really working the program and they cut them down a lot, whatever. So this point is, nicotine is a stimulant. It also can result in some bronchoconstriction. So they want to keep the cigarettes out of the picture. Coffee is a methyl, so caffeine, not coffee, but caffeine is a methylxanthine, so it can result in some bronchodilation. What they're saying here is they want to just keep it. They want to keep it as straightforward and not having these other substances interfere. Continuous maintenance medication. So if the patient's taking Advair Discus, take it every morning, they should continue to take it. Rescue medications, if they need them, they should obviously take them, but they should not take them prophylactically. May eat a light meal at least 2 hours in advance. And again, the definition of light meal would be really in consultation with particularly the physician prescribing the test, but also the individuals administering it. So the modalities, again, one versus the other. I'm agnostic. I don't, I feel the ergometer versus the treadmill. The thing with ergometers or exercise bicycles is it's lower impact, but it is what it is. So the ergometer tends to be cheaper, tends to be safer, all else constant. So if the individual loses consciousness on a treadmill and they're late and they're more advanced in the exercise protocol, they could injure themselves more readily than if they're on a bicycle, particularly if you're nearby. And if they look like they're a little funky, you can just have them stop. Versus treadmill takes 10 seconds, 15 seconds, whatever to stop. Again, can stop anytime. Direct power calculation, we'll talk a little bit about that. Independent of weight. That's not 100% true, but much more independent of weight than a treadmill. Holding bars, no effect. So, you can get the kind of idea where they're going with the advantages to the ergometer or the bicycle are more numerous. Treadmill, attain a higher, so it can be more rigorous with the oxygen uptake, which is VO2. Again, more functional. So what they're saying about more functional is it's more closely emulating or mimicking what you do every day. Walking, fast walking. God knows if a lot of you guys work in the hospital. I still work in an adult ICU regularly. In addition to doing everything else, I'm actually a lead therapist at a major medical center, 800 something bed medical center in northern New Jersey. I work adult ICU. Soup to nuts type of deal. And we are on our feet for, like you guys, on our feet for 11 or 12 hours out of a 13-hour shift, and we get our steps in type of deal. What they're saying here is that treadmill more closely will emulate that than a stationary bicycle. Equipment and instrumentation. So the treadmill, ergometer, the cycle is preferred. Again, some of the advantages we had there, ability to continuously monitor. The manual or automatic blood pressure device, a lot of them, it's almost hard to find a sphygmomanometer. I'm talking about the old fashioned type that you pump up and you got the actual, the analog pressure manometer on it. And, it's almost hard to find those. We actually have one at the hospital that's in our PFT lab, just to be clear on that. But on a lot of the floors, it's automated. You put them on, you press the button, boom, it goes up. Pulse oximeter is a must. Those portable pulse oximeters are little ones. They're now like $10, $15. They used to be, several hundred. Now they're not. So that's a good thing to have. In fact, last holiday season, the lead therapist, we bought all of our therapists, we bought them a pulse oximeter, bottle of wine, a little gift basket, if you will. Probably preferred the wine over the pulse oximeter, but in any event, we got them a nice little goodies there. Good thing to have for a whole lot of reasons, including, when you're doing exercise stress testing. Gas analyzers, we'll talk more about those. So mass spectrometer is the gold standard. And it really, that has to do with really closely measuring, the oxygen uptake, when if you know what's going, the amount of oxygen going in, the amount of oxygen coming out, you can really closely, calculate what's been utilized, the amount that's been taken up, if you will, the oxygen uptake. Breathing valves, and then the ability to measure volume. So the image that I showed you on the greeting slide there was the individual has, a mouthpiece or a mask that's on there, and it's actually measuring volume, but it's also measuring the what's the content as far as oxygen and CO2 of the gas that the patient's breathing in and they're exhaling. And again, just a little depiction here: treadmill, computerized ECG controller. It's also recording, etc. Ergometer, nothing fancy here, but just get an idea. It needs to have the ability to be adjusted per the desired protocol that's actually used. The protocol would be when you're increasing the stress or the exercise load, it needs to be done in a precise manner per protocol. Okay, so one of the protocols, for example, is what's called the Bruce protocol. This presentation is not all about protocols, but just understand that it really has to do with increasing things like, the resistance that's on, an ergometer, or the incline and or speed of a treadmill. Summary of the procedure. So, after screening the patient, their patient's connected to the monitoring equipment, and you can see, no surprise there. But they're also connected to either mask or mouthpiece for the FiO2, the exhaled CO2, and the volumes. Okay. Subject to increased workload. And again, the Bruce protocol, okay, I mentioned, is multiple stages of 3 minutes at each stage, the gradient and the speed of the treadmill. Okay, this is just an example. So I'm not, there's also the Botgay one, which is another one that's out there. So it's not about the actual protocol, but do understand it's not arbitrary. It's actually set in a very precise manner so that we can see that if, we have, Terry and I have 50 or 60 people in today's, in an average session that we have for our, CEUs. And if we were to actually, do cardiopulmonary stress testing on each one of us, it would be done in a consistent manner. Some of us, because of deconditioning, because of cardiac disease, because of pulmonary disease, whatever, we would at some point either not be able to continue, or we would, the readings that the equipment would get would suggest we're going into what's called an anaerobic metabolism. And I will talk more about that, which is clinically significant. It's going to suggest at that point, that's where the limitation is actually occurring. Parameters are measured at each step of the protocol, and calculations are done. They're actually done by the computer, so it's not like, sit there with a pen and paper anymore. Test is halted if the patient cannot continue. And there's again, adverse response, but there's, several indicators that are checked, that patients checked for. And if those were to manifest themselves, the test would be halted. The patient would be, the clinicians would stay with the patient, administer oxygen, administer rescue medications, things along those lines. And really, most of the, not protocols, but most of the procedures for cardiopulmonary exercise stress testing, they involve having a physician in very close proximity should the patient need some emergency treatment. Should they need, whether it be BLS or ACLS and any medications, things along those lines, that the response could be done very, very quickly, understanding we're putting an exercise load on an individual. Key feature of the test of the symptom limited exercise test. So you just, chest pain, patient may say, I can't keep up. So that's symptom limited. That's, I can't keep up. That's them telling you subjectively they can't. Measures airflow, saturation, expired oxygen, carbon dioxide. What they're inspiring is known. So what they're breathing in is known. What they're breathing out is known. The difference would be oxygen uptake. And the CO2, the amount of CO2 they're breathing in is negligible. That's what's in room air. And they'd be measuring what's actually being exhaled. So that would be carbon dioxide production. Okay. The relationship between VO2 and VCO2 is what's called the respiratory quotient. That's not a key part, if you will, of this lecture, but it is relevant because the respiratory quotient can be very valuable because it can also speak to the individual's nutritional status and perhaps be an indicator that the diet should be altered, perhaps to have less carbohydrate for a COPDer, because the respiratory quotient is significantly outside of the normal range type of deal. So I don't want to go on a tangent with respiratory quotient, but I do want to just say that relationship between VO2 and VCO2 is the respiratory quotient, and it can render some very valuable information to the team that's actually monitoring the patient. And then another talking about definitions. Well, this is another unit, if you will. Standard work unit used for exercise testing is the MET. It's metabolic equivalent of task. Okay, so one MET. Think about this. So one MET would be the average Jane or Joe's resting O2 consumption per minute. It would equate to that. All right. But the MET part is the actual calculation is 3.5 milliliters O2 consumption per kilogram of body weight. Okay, so it's relative to the patient. You would expect an individual who's 6'5" and 300 pounds, or 200, even 250 pounds, to basically be producing, or rather, have their oxygen uptake, their consumption would be higher than somebody. I'm about just under 5'10". I weigh about 180, 185 pounds. So I would have a lower oxygen consumption. So what the MET does is it adjusts for that. MET levels are varied during exercise by altering the treadmill inclinations, obviously the resistance on the ergometer, and most protocols increase again the intensity by 1 to 2 METs with each step. So the way they get the Bruce and the Bakke protocols is they back tested them for validity, and they kind of know for most individuals what would increase the exercise intensity by 1 to 2 METs with each increase in resistance and or incline. Indications to terminate. Again, many of these would be what you would suspect. Patients request they're fatigued, I can't breathe, and I'm not a little out of breath, because you would expect the patient to be a little out of breath. It's I can't continue. Ischemic changes, so things like ST depression, chest pain suggestive of ischemia, significant ectopic heartbeats, so where there's something going on in that department. Second or third degree heart block, no bueno. And then you could see some of your blood pressure measurements as well as your saturation measurements. And then some other some of the actual measurements that are examined. So pulmonary, if there's a ventilatory impairment, that could well manifest itself. If there's respiratory muscle dysfunction, impaired gas exchange. So on the pulmonary side of the equation, those would be some of the things you'd be looking for. The cardiovascular side, so reduced stroke volume. We have somebody with a severe cardiomyopathy, where the amount of blood that's being actually ejected from the left ventricle is not 60 or 70%. It's 40%. So ejection fraction. So it's stroke volume and ejection fraction are closely related terms. Abnormal heart rate response, where you get a paradoxical response where the heart rate doesn't increase concomitantly, and the patient gets extraordinarily short of breath. It may be that the heart has, it's a cardiomyopathy or some conducting issue where the heart can't really adjust. Circulatory abnormality, where there's, whether it's, peripheral vascular disease or some sort of a more central vascular disease, and some sort of a blood abnormality. And I will tell you, in extreme cases, the blood abnormality may be the patient's anemic. It could also be that the blood is too thick. They're polycythemic. So anemia is problematic because there's fewer red blood cells. But likewise, on the other end of the equation, it can be that the blood is actually too thick, and patients, they're COPD, or they're constantly, hypoxemic, so the body's produced more red blood cells. But it also becomes thicker, becomes more viscous. Peripheral inactivity, atrophy. So some of the others that you can see are malnutrition can play a role as well. And then you have some of the others where it could be psychosocial, where it's perceptual, it's motivational, where individuals just, and some of this, that some people can have psychosocial issues because they also have pulmonary issues. So they're not just, it's not just, these aren't mutually exclusive. Someone can have a cardiac limitation and a pulmonary limitation. It does muddy the waters. Okay, it requires more critical thinking on the part of the clinical team. But these things can actually exist. And then you can imagine if someone has both pulmonary and cardiovascular disease, can they also have a motivational issue as well? Absolutely. And some of the measurements of work, I alluded to many of these: oxygen uptake, which is VO2, VCO2 is CO2 production, and the others that are listed here. When we're coming down the last few, okay, particularly the second to last and the third to last, anaerobic threshold, I'm going to talk more about. That's really the point at which there's more oxygen being basically utilized than what the body can actually, get to where it's needed. And then you go into you start producing a lactic acidosis. Now it can be measured via an ABG, so blood lactate, okay? And there's actually some, even like iStat point of services cartridges that can measure them. As soon as you have the blood value, you can actually run it. It takes 2 minutes to run. So it might take you a couple of minutes to get the blood gas you're running it, but you can actually have a result if you're using a point of service system, such as iStat. You can get it pretty quickly. It's not sending it to a lab and waiting, an hour, half hour, or any nonsense like that. It really depends on the facility, though. So a lot of places would not necessarily have the ability to actually run a blood lactate, but you can actually determine where the bullet point above there, where the anaerobic threshold is. And I'll give you an idea of that when I show you some graphics. So some of the, the parameters, so minute ventilation, about 5 to 6 per liter, and it does increase, due to stimulation of respiratory centers. And basically, you have these proprioceptors and chemoreceptors that basically will say, oh, your arterial blood has, your venous blood has too much carbon dioxide in it. Arterial blood does not have enough oxygen in it, so you got to breathe more. You don't think about it, but it's what happens. Anaerobic threshold is, again, when minute ventilation increases more than the workload. So basically, body can't keep up. Tidal volume, so typically about a half a liter during exercise. It can increase demonstrably. Tidal volume can go, you can do the math here, but it can go to 4 to 6 times what it is at resting. Increases early in exercise. The breathing rate can also increase to, as believe it or not, as much as 40 or 50. Dead space, we'll talk about that as well. But let me just say this about dead space, is that what will actually happen, because of many moving parts, but including because the minute ventilation goes up so much, the dead space to tidal volume ratio will go down. So you have less dead space. Basically, the body, the lungs, the respiration of the body becomes more efficient as a compensatory mechanism, much more efficient. And then it decreases due to increased tidal volume with a constant dead space. So I have it in this presentation, but if you were to estimate physiologic dead space, it's approximately 1 ml for each pound of ideal or predicted body weight. So my ideal or predicted body weight is probably 160 or 170. So my physiologic dead space is probably 160 or 170 mLs with each breath. Some of the other parameters we're looking at is pulmonary capillary transit time. So it's normally 3/4 of a second. At exercise, it'll be cut in about half, roughly. Alveolar arterial oxygen difference. So again, you have some normal, it's about 10 torr. At exercise, it becomes even greater, because basically you have a lot more unloading that occurs at the tissue. So you have a lot of oxygen in the blood, but it's going out. And because the metabolism is so high, that the venous blood is coming back more depleted. So that difference is greater. Changes very little until the workload, heavy workload is achieved. Oxygen transport is another one that's altered as well. Some of the other ones that we'll look at quickly, I'm just going to, cardiac output normally 4 to 6, stroke volume. So stroke volume is just, 50 to 80 mLs. That's the amount of blood with each beat. Heart rate normal 60 to 100. Oxygen pulse, relative to, if you will, oxygen uptake to each heart, beat, if you will. So normally 2.5 to 4.0 mLs of oxygen per heartbeat. Just in an exercise that will go up demonstrably. So you can just see some of these compensatory mechanisms. Blood pressure, likewise, arterial venous difference is, again, what I alluded to as well, but basically, it's going to change as well in response to exercise. Oxygen, some more oxygen consumption. So normal, this is just what you might, this would absolutely be kind of the number that you need to know if you're taking the R or the CPFT. They want you to know what's normal because they might give you a value that's abnormal. I expect you to have some idea of what might cause something like this. But the normal is 250 mLs per minute. And again, 3.5 to 4 milliliters per minute per kilogram. Okay, increases directly with level of load. Give you a little bit more on the normal range if under stress conditions, if you will. Carbon dioxide or production normal. 200 milliliters per minute, and again 2.8 milliliters per minute per kilogram, just giving you a kind of a little more granularity. And anaerobic threshold occurs at about 60% of oxygen uptake, or VO2 max, followed by breathlessness, burning sensation due to the production of lactic acid doses. I alluded to the respiratory quotient, a relationship between VO2 and VCO2. Normal for us is 0.8, and again, basically during the test, it will actually alter that somewhat as well, considerably. So that's another phenomenon that happens during this testing. Now let's look at some. Let's take it away from the words and look at some, what's actually happening graphically. So what I alluded to before is this reduction in physiologic dead space. Okay, it's not actually reduction of dead space. It's reduction of dead space relative to ventilation. Okay, so in healthy individuals, the ratio is about a third, 35, 33, 35%. Of the ventilation is, I would say, wasted, but it's dead space. So it's not participating in gas exchange. That percentage falls down pretty demonstrably, owing mainly because the minute ventilation and the tidal volume goes up. So you're kind of seeing in this graphic here that the dead space drops and that the oxygen uptake, is really, as the oxygen uptake actually increases, as the stress load actually increases. And what's at play there is the fact that the minute ventilation is increasing at such a rate. And we're looking at, your tidal volume, and really expressed in the horizontal axis as a percent predicted vital capacity. Okay, and you can see at normal. Okay, so as the respiratory rate increases, and you see it going, 40. That's the, if you will, the up and down axis there. You can see that at 40, 50 breaths, and you're seeing that the tidal volume can go as high as about 60 or a little higher than 60% of a predicted vital capacity. So it can be very, very demonstrable. Individuals' tidal volumes can go from 500, and then during the peak of the test can be multiple liters, 3 liters type thing. Like, who has a tidal volume of 3 liters? Well, an individual who's at the upper end of their exercise stress test, nearing the highest level of stress, of exercise load that they're going to have, it can go up demonstrably. That's what this graphic is showing you. Blood pressure is just another physiologic response, and you can actually see. So your diastolic's pretty constant, but the systolic, so that Frank Starling's law of stretch. So that heart muscle is stretching and it's contracting, and it's stretching and it's contracting, and therefore your systolic pressure is actually going up demonstrably as well. Heart rate to oxygen consumption, pretty linear. Okay, So you have the heart rate going up there and the oxygen uptake is pretty linear. So you just, the straight line would be linear. One goes up, they go up proportionally and consistently would be your linear relationship there. And then this is really showing you the horizontal axis is work, and the work would be per the, let's say, the Bruce protocol. It's this very stepwise structured additional load that's actually put on the patient. And it's showing you what's actually happening with the minute ventilation. But at some point, that minute ventilation is going up disproportionately. Okay. And I will tell you, at some point, the patient is not going to be able to keep up. So they're not able to inhale the oxygen, all the oxygen that the tissues need. And the tissues, therefore, will go up into an anaerobic threshold. And again, this isn't this particular slide, but you know, if you were measuring blood lactate, you'd see at one point the blood lactate is going up disproportionately. Okay, and that's what's really known as the anaerobic threshold. And again, CO2 production. You know, the other one was showing you, oxygen uptake. This particular one is showing you CO2 production, but you see it becomes disproportionate, where it's not quite linear, but it's somewhat linear, and then all of a sudden it's just going up, demonstrably relative to the work. And a little more, relationship here. The relationship is actually looking at oxygen uptake and CO2 production, and where those kind of, if you will, intersect, and how that respiratory quotient is actually calculated, looking at these parameters. Now let's take a look at some basic interpretation. Indeed, we're coming down to the home stretch with this presentation here, but the variable, okay. And in the case study that we actually talk about, I talk about these, some of these, not each and every one of them, but you have PO2 and saturation. Okay, normal, we know what normal is, and you're looking at, what would happen during the test is something that's less than or equal to a 4% decrease. So if someone's normally sat at 98 or 99% breathing room air, okay, which is what you might expect, there's about a 4% decrease. So maybe it goes down to, from 98 to 96 or 95. You'd expect that change. But if it's going down to 88 and it's a good number, it's an accurate sat. Okay, so you would actually, be giving you some if you will, what's the clinical significance. So it could be decreased in interstitial lung disease and pulmonary vascular disease. It could be normal in heart failure, obesity, and deconditioning. So like I said in the very beginning of this presentation, these parameters can be very helpful, not necessarily singularly, but in concert with one another in screening, okay, for what's going on with the patient type deal. The second parameter is, if you will, A to A gradient. Okay, difference between the big A is alveolar, little a is arterial. Okay, so we want that to be typically low. Okay, in us, it's, without a diffusing defect, which again, I go into DLCO in another one of my presentations. Okay, without a diffusing defect that's clinically notable, you can expect that difference to be very small, less than 35 torr. However, with COPD, and I will tell you, with emphysema in particular, okay, that difference will be greater. Okay, COPD in general, particularly emphysema. ILD is interstitial lung disease, pulmonary vascular disease as well. It'll be normal in heart failure and deconditioned patients, okay, because there's nothing wrong with the alveolar capillary membrane in heart failure. I'm talking about pure heart failure, okay? Now, what can happen temporarily with heart failure is that the actual, lungs can get fluid in them, and it can affect diffusion. But a patient who's in active heart failure is not going to undergo an exercise stress test. So a patient who's controlled, but they have a history of heart failure or they're deconditioned, is that if you will, the A to A gradient is going to typically be normal. Okay, dead space ventilation. Okay, normal range is listed here. Increase in heart failure, COPD, pulmonary vascular disease, normal in obesity and deconditioned. And then some of the other parameters that we have here where you have minute ventilation to if you will, oxygen uptake, okay, at anaerobic threshold, AT, okay. Normally less than 34, and some of the parameters you see here. Increased in heart failure, COPD, ILD, and pulmonary vascular disease, and normal in obesity and conditions. So you're kind of seeing where dead space and minute ventilation to VCO2, to CO2 production at anaerobic threshold, okay, both of those two would be, again, increased in the same conditions and normal in the same conditions. Let's take a look at a few more here. VO max at peak. So really, we're talking about someone's maximum, if you will, oxygen uptake, okay? The figure that is normal is greater than 84%. And then what's listed here is the conditions that it would be decreased in, okay? And the AT is the anaerobic threshold, okay? Again, anaerobic threshold greater than 40% VO2 max. So what they're saying here, okay, is that the anaerobic threshold will occur, if you will, later. It should occur later, okay? However, it occurs earlier, okay, in heart failure, COPD, pulmonary vascular disease, and deconditioning. Okay, so again, you're looking at these different parameters, and if you look at them in total, not individual, but in total, it's going to allow you to kind of, or the clinical team, to triangulate the signal and to try to, if you will, in a stepwise fashion, look at what's normal and what's not. And then we have heart rate and heart rate reserve. What that's really talking about, heart rate and heart rate reserve, is you can calculate someone's, a normal heart rate and then their maximum heart rate. And typically when people are exercising, let's say they're training, they want to climb a mountain, or, literally mountain climb. They want to climb Kilimanjaro or something along those lines, is they're going to target like 75% of their maximum heart rate. Okay. So you can calculate the maximum heart rate. What this is saying is maximum heart rate, the heart rate reserve would be how much south of that maximum heart rate you actually are. Okay. And it's decreased in COPD. You can read the rest of the conditions, ILD, pulmonary vascular disease, and it's normal in heart failure. Okay. And the last two we're going to look at, and again, just in the interest of time and understanding there's courses that are offered on exercise stress testing. This is a less than 1 hour presentation, but oxygen pulse. Okay. Oxygen pulse, which really is relating oxygen uptake to each heartbeat, okay? And they're really saying, greater than 80% is what's normal, but it'll be decreased in the following conditions. It'll be normal in obesity. So one of the parameters you could look at, if someone is obese and, maybe they're, malinger, they're kind of faking it a little bit, okay, that you might actually see that the oxygen pulse is normal, but they're saying that they're short of breath, okay? Minute ventilation, the maximum minute ventilation, okay. Increase in normal heart or normal in heart failure, COPD, ILD, and these other findings as well. So again, individually, the findings are not insignificant, but they're not as significant as they are when the clinical team looks at all of these parameters in total. And you can, again, kind of through deduction, end up with, is it mainly a pulmonary disorder? Is it mainly a metabolic? Is it mainly cardiac? Is it none of the above? Okay. And it just seems like you may have a malingerer there. Simplified interpretation. So again, I'm not saying you should use one or the other, but some of these you can look at is, your breathing reserve. So calculate, the maximum minute ventilation, and then go 30% down from that. If it's heart disease, breathing reserve, greater than 30%, heart rate reserve is less. And it's for pulmonary disease, if you think of it, it's breathing reserve is greater than 30%, heart rate reserve is greater than 15%. So that's another way of looking at the same thing. So we'll spend a couple slides on, if you will, the exercise stress test, and then we'll just wind up the presentation here. So I alluded to this very early on in the presentation. 6-minute walk test measures distance a patient can walk on a flat surface for 6 minutes. It evaluates response to exertion and is used to determine overall functional capacity or changes in capacity due to therapy, in patients with moderate, severe heart lung disease. It does not measure a lot of the measurements, these specific discrete measurements that we just talked about. in the cardiopulmonary stress test. Oxygen uptake, CO2 production, no. METs, no. If such information is needed, again, the cardiopulmonary exercise stress test would be what should be done. Indications, some of them are listed here, but functional status, COPD, cystic fibrosis, not commonly cystic fibrosis, it is, but more COPD, heart failure. And then some of the pre-post, lung transplantation, lung resection, not commonly done, but for a while they would actually, can go in and take out a portion of the lung through like a video-assisted procedure. Many years ago, they used to use actually lung reduction surgery and things like pulmonary rehabilitation. The patient participated in pulmonary rehabilitation. Beforehand, they could walk X distance. And then now that they're done with the intensive pulmonary rehab, now they're in the outpatient, they're in the maintenance program. Now they can walk X plus, additional amount of distance. Some of the other disorders are listed there as well. Procedure, you got the contraindications are vaguely similar to what you have with a stress test. The American Thoracic Society actually has a protocol. This is an excerpt that's listed here, but the object of the test is to have the patient walk as far as possible, for 6 minutes rather. They should be told that they can get out of breath, et cetera, et cetera. That needs to be done very controlled. You need to have a chair nearby. You need to be monitoring the patient in case the patient, is getting really winded. They need to sit down. They should be allowed to. They're allowed to. They can continue the test, but that just needs to actually be considered as well. Stopwatch, movable chair, recording, worksheet, et cetera. Sphygmomanometer and other measuring devices should be used as well. Stop the test. Patient develops chest pain. The outcomes measure again, distance, dyspnea scale, SpO2, et cetera. And in most 6-minute walk tests will be done before and after an intervention, like I mentioned, if you will, pulmonary rehab. ATS still recommends that pre-post changes in 6-minute walk tests be expressed as an absolute value. The patient walked 50 meters further than what they did, before they participated in pulmonary rehab. Take home messages, home stretch time here. Cardiopulmonary exercise stress test can be very valuable. Distinguish among the causes of exertional dyspnea, disability determination screening for pulmonary rehabilitation, post-op, if you will, risk stratification, and assess response to therapy. However, it can be expensive and inconvenient. So again, there's other alternatives, including the 6-minute walk test, that if all that granularity is not needed, it can be used. Some selected resources are listed here, including 2 of my textbooks, but also some others that can be very useful. And with that, I want to thank you guys very much appreciate. Hopefully you learned something from this presentation, and we hope to see you again. Thanks a lot and have a wonderful day.